So thank you all so much for joining us in this discussion today. I'm really honored and delighted to be part of this discussion, and I feel that I've really taken on board Barack Obama's key messages to me to make sure I was the least intelligent person in the room and on the panel. So I absolutely feel humbled to be among the panel today. So I'm going to kick off maybe with David, obviously being part of Genomics England, myself being part of also living in the UK, universal healthcare, good medical training, Genomics England's vision for newborn screening. Is it going to be the blissful outcome that we're all hoping for it?
So thank you, and I do want to thank Illumina for inviting me to speak on this panel. It's really exciting to be here. Barack Obama really was amazing. I don't think I can quite match that. So the notion of newborn screening, I think, has been around for a very long time. And in recent years, folks in the US and a number of other countries have started to think about the possibility, could we use whole genome sequencing as an adjunct to newborn screening? And so with that, in the UK, there was a committee and some thought about whether this could work. And then more recently, maybe a year ago, there was a very large public engagement where the public really weighed in and said, we would like it if you would look for treatable conditions that you can identify or that will really present in the first few years of life. And so that was sort of really our marching orders to make such a program. And there are lots of ethical issues that arise in such a program. But I've spoken to probably several hundred specialists around England. And for them, they know, and we know, that these children who have these genetic conditions, these treatable genetic disorders, are going to present. And so the hypothesis is, can we get to those children? Can we sequence them, identify those children with disease before they get sick, in the hope that if we intervene before they get sick, we'll have a better outcome? And so one of the questions which is sort of what you're heading toward is, well, isn't this going to blow up the system? and so our initial program is going to hopefully start next summer. It will be 100,000 newborns, sequencing 100,000 newborns, reaching out to moms in the third trimester of pregnancy. And our ideal is to have a result within 2 weeks of birth for the physicians to call. And we estimate that, maybe 1 in 200 at most would be affected. So of those 100,000, maybe there's 500 positives and maybe there'll be some false positives, right? And so those 1,000 cases, even if we did them all in 1 year, they're spread across all of the specialists across all of England. So no specialist is going to find themselves sort of burdened with dozens of these cases. And when I say this to them, they say, well, that's not a problem, David. And in fact, I'm tired of going to the ICU and pulling some damaged kid out of the fire that if I had just known at birth, I could have done something before they got into trouble. So I think the hope and the vision that we have is to identify these kids before they get sick and use this pilot for us to learn how to do this and to engage with the public really about, do they think that was a good idea?
Yeah. And I think from my personal background, I started as a children's nurse at Great Ormond Street Hospital and later worked as a regulator of the European Medicine Agency in the pediatric team, really advocating for the needs of children first and foremost, and sort of arguing that children shouldn't be an afterthought. And, let's protect children through research, not protect children from research. And I think this is really exciting where actually we're starting at the point of childhood to really make. But even in the UK, for those that may be not so familiar, you've got Genomics England, and of course Scotland, Wales, Northern Ireland have their own infrastructure. And the UK is also a very diverse, culturally diverse community. So, how much of that is going to be scalable outside of England, but also how do you bring in that cultural sensitivity into it?
Yeah, I think that the cultural diversity issue is absolutely essential. The program, in my opinion, will be a complete failure if we really haven't engaged with all of the diverse communities. And in fact, that's a very strong part of our engagement team, is to identify how do different groups want to be approached and to meet them where they are. So there'll be some folks who will really say, I'd like to read more about this before I sign up, and that's actually part of the process. We expect several touch points during that third trimester. Some people will want to use their phone and the internet. Some people will want to call up and speak to somebody. Some people will want to get opinions from leaders of their ethnic community. And all of those are areas that we want to engage with so that people, moms and dads, who are signing up feel like we've met them where they are and that they've spoken to the people or individuals that give them confidence that this could be a good idea. Really, the whole program is about trust.
And I think, Nia, we had a wonderful conversation last night about very many various topics, and you were very inspiring in your stories of how you set up a lab in your secretary's office to start with, which is now scaled and very, very impressive. But one of the topics we covered that I think also resonated was this sort of cultural sensitivity and how to roll that with the communities. I don't know if you want to maybe talk about sort of your experience in Israel and that sort of
So in Israel, we have different populations. Some of them are very Orthodox Jewish, and those are not allowed to do abortions. So in many cases, before the matchmaking, there are anonymous testing of the male and the female into a anonymous database, and they do a matching of the potential to develop diseases, and according to that, the matchmaker will connect the two families together for the wedding. And this is being done under the support of many rabbis and many Jewish organizational big organizations that support the financial part of those testing, and everything is being done a very how do you say it? Everything is being done anonymously to prevent the stain from the lady or from the man who wants to get married. Because if she cannot be matched to one family, she might be able to be matched to another family, and this makes her continue the legacy and to get married to bring kids. And this is one of the most important for those religious Jewish people.
And I think that's what sort of resonated strongly with me when we discussed it, in the way that it was, created, the system was created by the community in the way that ensured there was no social stigma or casting people aside. And in Brazil at the moment, Mariana, you are kind of looking at maybe a slightly different approach, but a similar approach as well, which, I find particularly exciting, because you are trying to change in some ways the sort of reimbursement of where the money is allocated to prevention rather than cure. Do you want to just talk us through your plans there?
I would like to about what David said. I think it's very important to diagnose the treatable disorders, but also there is an issue about the untreatable disorders that can be inherited. So what do you do with that? For example, muscular dystrophies, most of them are not treatable, but they're inherited. So would you tell parents that they have a disease that is untreatable, but they have a high risk of having another affected child? So what we have been doing in Brazil is we are very concerned about prevention, because as much it's so important to treat this disease, we know that most of the genetic disorders are still untreatable. And we want to prevent the birth of other affected children. And even those that are treatable, the treatment is extremely expensive. So most of the family cannot afford it, to pay it. The government is paying for it, but is spending a lot of money with this. So what we are doing now, we are approaching our health secretary and saying, hi, you have to pay this huge amount of money to treat, for example, SMA. And we figure out that with the treatment of one child, we could screen 2,000 couples before they get pregnant for all recessive disorders. So that's something that we are fighting to try to have in Brazil to prevent the birth of more affected children.
And I think this is, it touches again on some of the topics that Barack Obama was talking about, sort of changing a creaky system, right? Because even if the science makes sense, even if the economics make sense, to change the mindset, to change the system, to sort of enable that is going to be quite a task. Do you feel that Brazil will, I don't know, adopt it quicker than maybe Obamacare was able to?
Well, we have to try. We are trying to do it. I'm very much, although I am a researcher at the university, I get involved in these kind of political decisions, fighting for it. And let's try to do it. In Brazil, because we are a lower income country, for a family to have an affected child is terrible, because the mother cannot work and all the family get to be very poor because they have an affected child.
And I think this sort of treatable, untreatable disease is also a quandary or a difficult one as to when to give the diagnosis. And I often wonder whether, as a parent of a child with a treatable disease, knowing that there is treatment out there but is so unaffordable that it's not likely to be available in your country, because we're working in a globalized world. So even if they know it's available in other countries, it sometimes makes it.
This is the worst possible thing
to be.
To know that it's treatable, but they cannot afford to
do it. I agree. And then, Natalia, there are some affordable treatments that are actually incredibly effective and not so expensive. And actually, repurposing some medicines can have profound impact and positive outcome on children that are born with inherited metabolic diseases if identified earlier, and like you were saying, before they are in an ICU where they're brain fried and trying to sort of recover that damage. Do you want to sort of share the combination when you have the rapid testing and the availability of cheap, affordable medicine and the success that can bring?
Yeah, absolutely. And so as laudable as David's efforts are to do, newborn screening, whole genome sequencing for newborn screening, there's still a subpopulation that will benefit from actually sequencing based on symptomatic presentation. A case that comes to mind that we just had the chance to revisit about a year after whole genome sequencing was an infant who made all the developmental milestones up to 1 year of age, no concerns, was doing very well, and then suddenly developed breathing difficulties. So was hospitalized in order to work up these breathing difficulties, and got a clinical diagnosis of an autoimmune disorder and was started on treatment for this autoimmune disorder. He, of course, did not respond. And during that course of the time, the family shared with us how they saw their son go from wearing 12-month clothing to 6-month clothing. So mom talking about going back home and digging and trying to find old clothing that could still fit him because he was not doing well at all. And at that point, the decision was made to do rapid whole genome sequencing since he wasn't responding to the treatment as expected. And rapid whole genome sequencing diagnosed this child in 72 hours with a ribosomal transporter deficiency, which actually can be treated with a vitamin B6. And so this child was starting at the same day on vitamin B6 treatment. We were able to actually visit with them very recently and could see him now as a preschooler running around, but still has the sequela of the time that he spent in the hospital, not being able to breathe, and received a tracheostomy. And so the family is wondering, well, if we would have known faster, if we would have known sooner, would he have needed this tracheostomy? But within the scope of things, the family is still very grateful because they were able to find their community. Now now that they had a diagnosis, there were other people with a similar diagnosis that they now could meet up with and talk about and share information about how to better treat their children and what other things they need to be concerned about. So there's always, I believe, going to be the need for symptomatic-driven whole genome sequencing because your newborn screening panel is still going to be a panel. And who gets on the panel and who decides what disorder gets on a panel is going to be very critical for these panels.
I mean, I completely agree that the use of rapid genome sequencing has really revolutionized how care is practiced really in lots of places around the world. Mm-hmm. And clearly with newborn screening, some of these children are going to present in the first 2-3 days of life before you have a genome available. We're aiming at 2 weeks of age to have a result, but if you have ornithine transcarbamylase deficiency, you're going to be hyperammonemic at 2 or 3 days of life, and so those physicians are going to have to do what they normally do, which is to treat those children. And maybe someday we'll be, in the weeks or in the 2 or 3 weeks prior to delivery, we'll use fetal cells from maternal or fetal DNA from maternal circulation and be able to do a genome from that. And so, maybe we can just push the time back a week or 2 or 3 from delivery, and that would make all the difference to these children, for example, with OTC deficiency.
Yeah, absolutely. And I think it brings the question of sort of equitable access to testing and the way we talk about equitable access to treatment, really. And you were mentioning in Israel when you sometimes get asked to do some testing for patients that have got, potentially not able to afford it, but needing to. So how in the healthcare system do we sort of ensure that the testing is available at an equitable kind of access?
So that issue is pretty tricky because there is a delicate balance between how much you can do as compassion and how much needs to cover the cost of the lab. So when we speak about a whole genome, we need to have at least 24, 48 newborns or samples to get the most efficient analysis in terms of financial cost. And in many cases, you have to run partial runs that increases the cost for each diagnosis. And when you add to that equation the urgency of the diagnosis, and you need to bring a result in less than a week and not 2 or 3 weeks as usual, it always pushes you toward the high end of expenses that not necessarily reimbursed by the state or by the Ministry of Health. So last week I had a request from an oncologist colleague of mine who asked for an urgent diagnosis for a young 44 years of age with testicle cancer. And the system could not support the financing of the testing, and he asked me as a favor to be able to do that for him when the patient has only 3 or 4 weeks of living, according to an oncologist. So we had the holiday, so we couldn't start doing the test, but we are going to do it next week, hopefully for him. Currently, without any compensation about it, if we are able to try and save his life or maybe find a treatable mutation for him. But this raises the idea that we need to find a way to generate a fund or a tool that will help us treat or test those people who can't afford paying for that, especially for diagnostics that are not in the health basket.
Mm-hmm. And I think that there might be some value add in looking at how that's been done for compassionate use access of medicines or early access schemes, or if the clinical trial's not running in certain countries, and that might be something that should be considered in the community soon. But a lot of it is also about education and the education of clinicians and understanding. And Natalie, you were talking about you run the hospital, you're in the site, but sometimes the clinicians are still not as eager, or it doesn't cross their mind to be first and foremost in terms of referring for this testing?
Yes, so absolutely, because the way that this has been shown to be effective has been in a critical care setting. And so if a child came to my institution and was in the intensive care unit, the thought of going to rapid whole genome sequencing would occur quicker to those physicians than the physicians who take care of the children who come straight from home. They are coming sometimes, walking, so you don't expect them to be critically ill, and so it will have a little bit delay into maybe I need to do something else. We are limited by the fact that a lot of diseases look the same way, and so which one are we going to start treating? And so we kind of have to make a decision at that point to go with the most likely diagnosis. But having a whole genome sequencing can just lift the curtain on this and help guide us a little bit better. But not everybody is there yet, even within the same institution. The lingo is very different. We have to learn what all of this means. People are maybe a little bit afraid of talking to families about these diagnoses, so we have to rely on our colleagues who are specialists in genetic disorders, and there are not too many to go around. Not every hospital has a geneticist, for example, and so we need to be able to have them come in and talk to families. There's a dearth of genetic counselors. Not everybody's available in the hospital. Some of them are in industry. So education, I think, is going to be very crucial in how we can advance the incorporation of whole genome sequencing in other settings that are not the critical care settings.
And would it be fair to say that education and training for doctors and nurses today is just not fit for purpose, that education and learning is not keeping up with the science, or sort of, I don't know, across, we've got good global representations here, I guess slightly different training approaches, but in your countries, is each of the medical training school, nursing schools fit for purpose anymore?
Oh, I teach medical students, and we think it's extremely important to have them understanding. What happens in Brazil now, there are many private labs that are offering genetic studies, whole exome, and then they do a copy-paste of what is in the internet without looking at the patient. And the patient writes and says, well, I don't understand what is going on here. According to this report, I should be dead now. And so we have to translate to patients what is the meaning. And so I think it's extremely important to have the medical students and the doctors learn more about genomics. Yeah. But I would like to ask something to David. What do you do with incidental findings?
That's a perfect question. Incidental findings is certainly something that we chatted about. And we're very directed by how the public want us to approach this, because they're paying for it. Mm-hmm. And so the position that we're taking presently is we're going to have genes where there is a treatment available, and we're going to select genes where we expect the phenotype to present in the first few years of life. We're also actually going to select pathogenic and likely pathogenic variants. So we'll have variants chosen on the program, not just the genes. And of course, we'll include, like, if there's a variant that's that's presumed pathogenic, like a premature stop or a frame shift. But we'll have a set of genes and a set of variants, and that's what we're going to look for. And we are telling folks, parents who are involved, that we're not going to look see if they're a carrier, if their child is a carrier for cystic fibrosis. We're not going to look to see if their child has a risk for breast cancer. We're only going to go after these treatable, early onset genetic conditions, because that's the area that there's a lot of consensus around. Now, there are two other parts to the program, which I really didn't get into. One is a research aspect, where we're going to ask families to allow us to use their child's genetic information and clinical information to help us discover more diagnoses, but also to help try to discover new treatments. So that's another important aspect of the program. It's not just to look for treatable conditions, but to advance knowledge so that we can have more genes that we could treat and have more treatments. And then there's actually a third part, which is sort of the lifetime use of the genome, right? So when one of these individuals reaches the age of majority, they may want to take their genome and look for other things, like risk for breast cancer, or you could imagine a child who's negative with our screen, and then at 2 or 3 years of age, their physician says, well, I think your child might have a genetic condition, to be able to go back and look at that genome. And so those are sort of this sort of lifetime use of the genome, which has many sort of ethical and sort of social concerns. You know, is the data safe? Who's allowed to know about it? You know, what control do we have over the data? And obviously, you know, if somebody says we want our data removed from the program, of course we would do that. But these issues of what secondary or incidental findings in the beginning of the program, again, because we're trying to have consensus among the physician community, the National Health Service itself, the patients, the place that everyone seems to coalesce around is this notion of treatable genetic conditions. But these other questions are very important and are sort of being actively debated.
Well, I think it's very important what we are saying, but I want to tell you a story that we had. A child that had a diagnosis that we want to diagnose muscular dystrophy, and we did the whole exome, and we found a mutation for breast cancer. It was a boy. So we decided, we always discussed cases, and we said, well, why should we tell these parents that the child has a mutation for breast cancer? It's not related to his disorder. And then everybody agreed, and then someone said, and what about if his mother has this same mutation and this can be prevented?
Right.
So it's a difficult issue.
It's a very important issue. I could not agree more. There's a gene BRCA2, which is associated with breast cancer. But if you have a DNA change in both copies of BRCA2, you'll have Fanconi syndrome, Fanconi anemia. Those children need a bone marrow transplant. And so this is bringing us right up against the reality of genomics, which is that we are going to talk to families, right, about a child who has to have a bone marrow transplant, but at the same time, those parents are both going to find out that they are carriers of BRCA2 mutations and so are therefore at risk for cancer. So these are the kinds of discussions that our ethics group has been sort of deeply involved in. And I will say that we have an ethics team and an ethics lead and an ethics committee that are thinking about like every aspect of the program. It's not just, oh, they're involved in the consent form and then we're done with them. It's not like that at all. And so this exact discussion that we're having has been, people have been thinking about this very carefully. And I think where we're sort of come to is we need to tell moms and dads at the time that they're signing up what they're signing up for. And the sort of things.
And if I could jump in at that, because, you know, having supported many families through clinical trials, and the informed consent is always the most important part of the discussion to take part in clinical trials. But actually, when you ask them, you know, 6 months later, a year later into the clinical trial, what do they remember about the informed consent? Absolutely none of it is really understood or really absorbed, and so many of them, you know, that's why we struggle a lot with retention in clinical trials, because it's really hard to grasp, you know, you don't know what you don't know, and that impact on clinical trials. And I do still worry that even with consent, do we really enable informed consent of what this could, the domino effect of what this could roll out to be in that sense. And yeah, there's informed consent, and yes, the physician could be brilliant about explaining what they are doing, but if you're a, you know, excited mother in a different world, then I'm not sure that would really always be sort of understanding what you are kind of embracing. And I think in the UK, if we go to the point about storing your genome for future, we do have the right to be forgotten, and there is, but with all our digital footprints that we're sort of creating, from social media to electronic health records to everything else, there will come a point and a real concern of, how this data is generally segregated and can't be linked up. And I think it's going to be one of the biggest challenges, that we are creating something that we don't know what the outcome will be, and we don't know how to put the right gatekeeping and the right infrastructure to support that. But not to get too negative, maybe if we go back to what are the right skills to take this forward, Nia? We talked about education of doctors, but we also discussed about the value add of having a multidisciplinary team and a change of career. Where does the sort of future hold in terms of bringing all these disciplinary fields together to move it forward?
So, that is a good question, thank you.
I mean, your personal career, I guess I'm reflecting on your personal career. You've had different chapters, right?
This is a good time for the teaser from my Under the Lens, but
yes.
So actually being able to bring a different way of thinking and different way of doing things to the public health helps to do it faster and better than it used to be. For example, today in Israel, the average time to do a cancer diagnosis for a molecular panel is 4 to 5 weeks. We were able to do it in less than 2 weeks, and we keep holding that pace and trying to reduce it more. Similar. We are having new technologies to the lab, either automation or having multiple sequencers and finding the right PCR machine that will do it faster, or maybe a little bit more cheap and more efficient. All together brings a package that provides faster diagnosis, more affordable for patients that are not covered by health insurance. And also more accurate, because you need to pay attention to anything throughout developing the process, and it makes a huge difference. We did it with COVID, we did it with cancer, and we hope to do it in the near future with liquid biopsies and NIPT and anything that can improve life or prevent suffer.
Yeah. And Natalie, from your side, where do you see the future in terms of sort of this moving forward in a way that works in the system that you're currently operating in?
So I think at times it's very humbling to speak with parents, because we give them a diagnosis, and then the child gets out of the hospital, and there are still challenges out there. And so my concern is the infrastructure. How do we support families? How do we get them to the right support groups? Who is supposed to do that? I would even go back to David, like, who is going to do the consent for the newborn screening? Because it's a time-consuming process. As a physician, if you go and say, okay, you need to do this also during your clinic visit, that's something else to do. And are we going to do it well? And who's going to train us to do it well? And so I think that those are the things that concern me mostly. I'm grateful for this technology. I've seen the impact on the type of healthcare that I can provide and the impact on the children, but I also don't want us to lose sight of what happens afterwards, or how do we support these families. So biggest thing for me is, like, how do we build this infrastructure?
Yeah.
And
I mean, that's 100% correct, and I think that's one of the things that been a lot of thought, in terms of this newborn program, is to be sure that it's one thing to make the diagnosis. It's still the same to have them seen by the specialist. But for retinoblastoma, there are basically 2 centers in the UK. And so we need to make sure that there are travel funds so that these children, so the way you manage retinoblastoma in a newborn is you do an eye exam under anesthesia every 6 months, and you bring a laser along with you. And if you see an incipient tumor, you zap it right on the spot. And so people, you could imagine, having to travel from all over England. So that's one of the areas that we're very careful to think about. For each of the diseases that get on the program, how will mom and dad get from A to B? And so that's really important. And sort of to get back to something you were saying before, which is about consent, and you were saying about consent. So we think about consent as a process, but one of the things that we're really wanting to do with this group of individuals is to have a relationship with mom and dad for a longer period of time, because we not only need to find out the children where we find something, but what about the children who have a medical condition that you failed to find? Because it's a screening test. We are going to, for sure, miss some of the children who have the conditions we're looking for. And so we want to have a relationship with those families for several years to come. And our hope is, with some questionnaire kind of things, we can get at the kind of issue that you brought up, is like, people forget what they were. I mean, how many people here are sure that when they go to the doctor, that they go to their doctor and they absolutely remember everything the doctor said? Anyone raise their hand? No, no one raises their hand. I hear like 10% of what my doctor says, right? So it's the same problem for these parents. And so that's where this relationship, I think, is going to be, is our hope.
Can I have a provocative comment? I think that most of the people don't read the consent form.
Well,
we sign consent forms all the time in the internet. I want to know who is reading all these things, and if you don't sign it, you cannot reach the platform or whatever.
I mean, I have to be honest and admit that even on this conference, when I was uploading my COVID testing and my vaccination screening, I have to admit I didn't read a word, but I signed and pressed submit. And you know, if anybody asked me anything about what I consented to, in that, you know, and I had all the time in the world potentially, but it was a lot of words to be processing on my phone.
In small letters.
In very small letters.
We do imagine that we were going to have people walk through the consent, but then ask them a question, and then they would be allowed to sign. If they got it wrong, they could still move forward, but to try and have an interaction with them during the consenting process.
And I do think, so, you know, in the UK at the moment, and you know, post the pandemic, we are really struggling to retain doctors and nurses. We are, you know, low on numbers. A lot of people are leaving the profession early. You know, we are a biased group of people in this room that is interested in this, right? But if your day-to-day job is everything else, and you're exhausted and exasperated, and it takes you 10 minutes to get a very old PC to come into life, and you have 10 passwords that you can never remember how to get into, and then somebody's asking, oh, but why didn't you remember to send rapid genome sequencing along? So I think that part of this infrastructure, informed consent, should be about relooking at digital digital information in a way that makes sense to people in today's age. So it has to be multimedia, more informative sort of learning along the ways. Otherwise, I mean, particularly when we have a strong anti-vax conspiracy theory kind of group going along too, if we don't really proactively kind of address this educational piece and bring the informed consent kind of experience with some personal touch, because at the end of the day, when you are faced with these disease kind of outcomes, you still need the personal touch there, I think, which...
Absolutely. So I loved your idea of developing a relationship with the family, because there's also, and I know you're going to be very careful, and because we're also delving in that area, we're going to be very careful in what variants we pick to put on this whole genome sequencing, but sometimes some diseases present earlier or later in childhood. So are they going to present as a neonate, or are they going to present when they're 2 years of age? And so being able to support families where they're living with this diagnosis, but their child is developing normally. So where do they go? So who do they talk to? So I love the idea of developing a relationship and being able to stay in contact with the families.
Yeah, I think that you know, the whole program is just built on trust, So I'm on the NHS, right? So that's how I get my medical care, and I love my internist and everything like that, and they're really fantastically kind. And so there's a lot of very positive feeling in the UK about the NHS. There really, really is. You know, everyone complains, but everyone really actually loves the NHS. And so we feel that in this program, we're trying to maintain that trust. We start with good feelings from the folks in the population because the NHS is deeply involved in running this thing. And so that's kind of our responsibility, if you will, to maintain that trust and have those relationships. And we're going to make mistakes, right? That's going to happen. And just to be, you know, honest and be with the families. I think that's what's going to help.
I think, you know, it's really heartwarming for me to hear you say that people do love the NHS. You know, Anira Bevan was Welsh and sort of was pioneering to get the NHS there. And so for us fellow Welsh, you know, it's a really important part of our, and it is really difficult now in the UK when we see so much attack on it and so much risk to this sort of universal healthcare, while it not be perfect, be at risk in terms of being, and then the impact of that. So we're wrapping down to the last sort of 4 minutes. So I want to give each of you sort of a minute each now to reflect about, hopefully we'll have the opportunity to regroup here in say 5 years time. And what do you, you know, two questions. What do you want to see, and what needs to be happening in the next 5 years to make that happen? So I don't know who wants to go fast, who's a quick thinker.
I guess I'll go. David, I was going to piggyback off of you, but I'll go. I think in the next 5 years, I would love to see whole genome sequencing get incorporated in newborn screening, because that would increase the number of children that can get diagnosed with diseases in the vein of how newborn screening was developed, was to diagnose treatable diseases. I would like to see an increased workforce in support system for the families, in order that we can have somebody that can check in at all times, and a way to stay in contact. Like, we don't have a universal healthcare, so we are dependent on whatever healthcare the family is involved with for things like symptomatic whole genome sequencing. But newborn screening equalizes the field, so that's why I'm very supportive of that, and hope in the next 5 years we will have that very well incorporated, but also with a nice infrastructure to support the families.
Brilliant, thank you, Natalie.
Well, I'm going to talk now as a researcher. We are screening the population. We have screened already a whole genome sequence of 1,200 people from our population. Older than 60 years old, we decided to focus on older people, because then you'll know if they are at risk for this Parkinson or late onset disorders. And we found 2 million variants that were not in the UK banks or other banks. And with this, we can improve very much the precision medicine, because several VUS were present in our population. And now, so we need more funds, because we have more 30,000 people that are ready to be sequenced, but we need funds. So this is a message to Illumina to help us, because this will be very important, I think, for diagnosis of precision medicine all over the world.
Absolutely, it's a very good plug. But I do want to try and hold you to that vision of getting the Brazil healthcare to pay for this preventative one as part of the whole one. And Nir, for you?
I think that it should be a centralized database for all the variants and all the genomes together to allow scientists and physicians from around the world to collaborate and to identify that rare specific disease that was not reported in any paper, and being able to find the right person, the right physician, and to share the insight and the knowledge. And the second thing is about cost. So if you want to have a genome for everyone, or a genome on a key, or whatever you call it, cost should be down dramatically to allow it to be really accessible to all the population all around the world, and not only for Western countries.
Yeah, I think this fair sort of access to data and interoperability of that is really going to be a key part of it, that the more the data is used, the more value that we get out of it. And David, what about you?
Yeah, I mean, the notion that you could screen very large numbers of children all over the world for these treatable conditions, and many of these treatable conditions, the cost of treatment is a vitamin or some incredibly, incredibly inexpensive approach. That's kind of what moms and dads want the people in this room and on this panel to do. They want us to get going and have a system where their children who are going to get sick, you're going to find out about it before they get sick. Help us. That's what moms and dads are saying to us. And so truly, I agree with my colleagues here that when the cost comes down to do a whole genome, that's when the magic of helping these children will happen.
Mm-hmm. Excellent. Well, thank you so much. We're up on time, and I think we can wrap up in the hope that we'll all be invited back in 5 years' time to see how it goes. Thank you very much, everyone. Thank you very much.